We're doing good. Hello, YouTube. We are doing a live drop-in IC support group meeting. It is Wednesday, July 3rd. Our topic today is IC caused by bacterial, viral, or fungal infections? We tried doing this a little bit earlier today. Facebook was down, so I decided to shut it down. We're trying again. My intention is to try to broadcast for a couple of hours if we have people who have questions. So it is a gorgeous July 3rd here in California. Beautiful, warm. It's warm. In fact, you're going to see me sweating. I'm going to turn the. Let me know. I'm going to turn the air conditioner on. Let me know if you guys hear it. If you do, I'll turn it off. Alrighty then. Oh, it's been a busy day here. This is, you guys, I'm telling you, when it comes to IC, this has been seriously the most stressful year. If you see bags under my eyes, that is why. That is why. We, between the Elmeron eye stuff and the Cysto Protect cancer warning, and now there's even a worse consumer alert. I'm waiting for advice from my medical board before I talk about it. So I'm not going to talk about it now. Let's see if, oh, okay. Okay, good. Okay, so here's a response from my medical board about this thing that I wanted to talk to you guys about. Okay. All right. So let's just do the basics here. I'm a support group leader. I'm the National IC Support Group Leader. My name is Jill Osborne. I'm the CEO of the Interstitial Cystitis Network. I'm also the longest serving IC support group leader in the United States. There's I think one other person in the Netherlands who's been doing it as long as I have been doing it. My goal with these meetings is to make you so strong, so knowledgeable, so informed that no one can mess with you ever again. That no one can tell you that it's all in your head. Nobody can tell you that there's no treatments, because I'm here to show you that there absolutely are treatments, that there is hope. There is tremendous hope. There's tremendous hope if you are struggling with pelvic pain. But it takes a lot of work on your part. You know, this is a giant mystery that we've got to solve here. We've got to figure out what's triggering your bladder and your pelvic pain. It could be traumatic injury to your bladder. It could be chronic infection in your bladder. But if you're a woman, it could be fibroids. It could be endometriosis. For many, if not most people, it is pelvic floor dysfunction, pelvic floor injury. As an example, I was working with a professional football player a couple of months ago who literally out of the blue had the typical symptoms we would associate with IC: frequency, urgency, pressure, pain. And in his case, he had sustained so many injuries to his pelvis area and pelvic floor. He had massive pelvic floor dysfunction. And so all those quote unquote bladder and prostate treatments never had a chance of working for him until they actually found his muscle injury, right? So on our website, the ISEE Network, we have a lot of videos that you can watch. We got a lot of good educational information that I hope will help you understand more about that. If you've never visited our website, icenetwork.org, that's icenetwork.org. I want to remind you that I am not a doctor. I do not give you medical advice. My goal is to plant seeds of knowledge and to tell you where to get more knowledge. And if you hear something interesting, I want you to take it to your doctor and talk it over with your doctor. Alrighty? That is important. My job is to bring you and your doctor closer, not to separate you. I want you to don't walk away from medical care, but I want you to walk in so knowledgeable, so informed, you can direct your medical care and you consider your doctor your partner. I don't want patients to be patient. I don't want you sitting at home suffering in silence, laying in bed. For God's sake, no. We're going to be active. We're going to be strong. We're going to be informed. We're going to make appointments. We're going to ask questions. We're going to ask for tests. We're going to kick some butt here because our goal is to feel better. And I say our because I'm an IC patient too, just like you. I was doing really well. I've been pain-free for almost 10 years until my hysterectomy 2 years ago. And now I'm back Um, ugh, you know what I mean? It's like, oh God, God. So I'm a little scrambled today. As always, I'm happy to take any questions you have. I do these meetings in three sections. For about the first 30 minutes, we do some educational content, and then I'm going to take your questions for however long you've got questions, and then we usually do some sort of giveaway. Alrighty, so let's go right into our educational content, and that is the role of infection. Is IC caused by infection? Does every patient watching this have infection of some type? Now, if you've watched these videos before, you now know that we do something called subtyping because we want to, we look at every patient as a snowflake. Everybody's different. And to make blanket statements that everyone has infection is a terrible mistake because if you spend any time in a support group, one of the things you really see clearly from the beginning is how diverse we are. So some patients have bloody bladder walls that look like bloody hamburger. They've got bleeding lesions. Others, like myself, entirely normal bladder. Both of us diagnosed with IC. Are we the same? Absolutely not. And when you actually get into groups and you ask patients, when did your symptoms begin? That's where you really see the diversity. Because for some of us, IC begins in childhood. While for others, IC begins after menopause. For some, IC begins after a fall, breaking your tailbone. While for others, IC begins after chemotherapy. All diagnosed with IC, but are we the same? Absolutely not. Absolutely not. So we're now doing something called subtyping, so we can try to understand your unique variation of IC. And I've got a great video on our website about it, and I'm happy to go over it again today, but I think we can kind of skip through that. So getting back to our core fundamental question, is IC infection? 20 years ago, 25 years ago, many people believed IC was bacterial in nature. And there was a wonderful doctor named Paul Fugazzato. I met him when he was probably 75, 76. He ran a lab in South Dakota called the Cystitis Research Center. And we all had a nickname for him. His name was Dr. Fuzzy, Fugazzato, Dr. Fuzzy. Lovely, lovely, lovely man. I had lunch with him. I liked him. I thought he really cared. He believed that everyone with IC, or most people with IC back then, had what we call a fastidious infection. What he meant was that it was sorry, I'm just moving stuff around here. What he believed was that it was a small, deep infection somewhere in the bladder. And so he asked patients to send him urine samples. And we all did. I did. I mean, he must have had a couple thousand urine samples. And what he did was something called a broth culture. Because the theory behind a fastidious infection is that it's hard to grow, that it's hard to isolate. You're not necessarily going to see it in a typical agar plate urine culture for 24, 48 hours. So it would not grow out quickly or in sufficient quantity to be identified properly in typical urine testing. So he would send out little glass jars about this big. We'd pee into it, wrap it up, send it back to him, regular mail. It wasn't overnighted. And then he would give us our test results. And in my case, he found that I had enterococcus and micrococcus. And in my mother's case, it was the same thing. And then his recommendation at the time was in-depth long-term antibiotics. Now you got to understand, Dr. Fugazzato wasn't a urologist. He was a microbiologist. I wish that I could tell you what his exact degree was, but I don't remember what it was. He ran a lab. He wasn't seeing patients. But his recommendation was that we all take high dose long term antibiotics. And we all did. I did. I mean, what else did we have? I mean, this was before Elmeron was approved, right? We were all desperate for answers. He made a fairly plausible argument. And so it was what everybody did back then. And so what I did is he wanted me to take Augmentin for 3 to 6 months. I took it to my urologist. My urologist said, "Oh, hell no, you're not taking Augmentin for 6 months. But I'll give it to you for a couple of weeks." I think I took it for 4 weeks. Did nothing, absolutely nothing for my IC. And what I did get was a 2-year-long drug-resistant Candida glabrata infection from this week-long sojourn. Now, at that time, the ISEE Network, because we were, very progressive on the internet, we did about 100 guest lectures, free meetings where you could come in and meet the top doctors in the country. And so we had actually the head of the National Institutes of Health, NIDDK, it was one of our guest speakers. All the top IC research were our guest speakers. You named it. We had Rob Moldwin, we had everybody. And I asked every single one of them what they thought of Dr. Fuzzy's theory. And their answer was that they really believed that there was a flaw in his methods. Because what he was doing is he was reusing glass vials. So I don't know how many he had. He'd get them back from a patient, throw them in an autoclave, which is heat sterilization, and then he'd send them back out. And we had already learned that some bacterial biofilms survive autoclaving. And so the general theory among the vast majority of doctors I talked to is while he had a compelling, interesting idea, that his methods were flawed and that he was pushing out some false positives. And that was absolute consensus among every big IC researcher that I talked with at that time. At the same time, the University of Maryland was absolutely the top IC research center. Their program has since been disbanded, which is really sad. Because if anybody at the University of Maryland stood up at a meeting with new data, the entire room stopped to listen to them. And the top researchers at the University of Maryland were Jack Warren and Susan Kie. And so Susan Kie embarked upon a study to look for consistent bacteria using, I think she was using early next generation methods, but I'm not sure. Again, this was like 18 years ago, 20 years ago. Okay. So they were doing much more aggressive testing than Dr. Fuzzy, looking for bacteria. And they were studying many, many patients. And they never found a consistent pathogen in this group of patients, never. They didn't even find trends, patients were all over the place with respect to bacteria. So we couldn't make any claims that a specific bacteria was causing IC. But what she found something entirely different. She found something called the antiproliferative factor, APF. It was a protein. And it was a protein found in almost every IC patient that appeared to limit the ability of our tissues to heal. And that was stunning at the time. Stunning. I tell you, I'm not lying. If Susan Kie was appearing at any IC event, any urology event, the entire room stopped and listened to her because she found something no one else had ever found. So the question was this protein external, something that we were exposed to, or was it something that was part of our bodies anyway? And the consensus at that time was that it appeared to be being manufactured by the bladder for some reason. Of course, we had great hopes that the antiproliferative factor would lead to some new urine tests, because if we could have an easy urine test that looked for antiproliferative factor and give you a de facto diagnosis of IC, that would be fantastic. And that was, many researchers tried to do it. I know that because we reviewed those on the Army research panel that I was on, but no one was actually ever able to make that financially work. So it was really at that time that she published her data that the antibiotic theory kind of died. I mean, the bacterial theory kind of died. Now, Dr. Fuzzy had his supporters, very, very vocal patient group, a couple of professionals, one or two in the nation. I won't say who were progressively on the internet saying, "Hey, you've got this deep fastidious infection," yada yada yada. So things calmed down for a while. It was like, okay, bacteria not involved. And then the Lyme disease community came out very, very aggressively and said, we think most IC patients have Lyme infections in their bladders. And if you spend time in the Lyme community, you see that Lyme disease patients do definitely have bladder symptoms. Many have been diagnosed with IC. Just no doubt about it. And in fact, it was Dr. Michael Chancellor, one of the top IC researchers, who early in his career was the first doctor to find Borrelia, the bacteria for Lyme, in the bladders of Lyme disease patients. So what did we all do? We all signed up for Lyme tests, myself included. And a small population of you did have Lyme. So that's kind of the first real confirmation that at least Borrelia can live in the bladder wall and can be very, very difficult to treat. So if you as a patient live in an area where Lyme is pervasive and common, like I was working with a patient like 2 weeks ago who just found out she had Lyme, and she'd had symptoms ever since she'd been in this area where Lyme was very common. So it is now due diligence, absolutely, to have a Lyme test. If you live in an area where Lyme is common, if you've been bitten by a tick, even if you haven't been bitten by a tick, but if you were a hiker, why the hell not? Worth doing. I did it. Mine was negative. And I think we don't have a good statistics study on the rate of positive and negative, so I'm just relying on my personal experience here. I think the percentage of IC patients who have, quote, Lyme disease is actually very, very small, like 2 to 3 to 5%, maybe. That might even be really, really high. But that is absolutely something that is worth ruling out. So if in that subtyping system you're falling in IC subtype 2, bladder wall driven, you have pain as your bladder fills with urine that is relieved by urination, get yourself checked for Lyme. Why not? I mean, this is where we patients get stuck, because you've seen a local provider or two, you've given you stuff, it hasn't worked, you're suffering, nobody's listening to you, and you're basically at home in bed. I need you to get your ass out of bed, and we need to start ruling stuff out here now. We're going to rule some stuff out. And Lyme disease is absolutely worth ruling out. Okay, so we started with Fuzzy, then we went to Susan Kie, and we came to the Lyme community. But then the National Institutes of Health MAP Research Network, which is a multidisciplinary approach for the study of pelvic pain, funded by the National Institutes of Health. It studies IC and it studies chronic prostatitis. They too have looked for that elusive bacteria. They too have not found it, but they made another remarkable finding, because what they found is that many IC patients who are flaring have an overgrowth of Candida. You got to remember, guys, here, I got to turn this air conditioner on. Okay, so like, remember that 25 years ago, we all thought that urine was sterile, right? We all thought if you had symptoms, frequency, urgency, pressure, pain, it was a bladder infection, right? And yet, this whole kind of candida thing, I mean, I would hazard to guess for the people watching this, for the women watching this specifically, I bet a lot of you have gone through periods of time where you've struggled with yeast infections. And I remember the first doctor that I saw for this, his name was Mark Klein. Loved him. He's retired now. Fabulous doctor. Um, I said, Doc, this is so weird because for my first year, the same thing always happened to me. I had vaginal irritation the first day. Then I would have vulvar irritation the second day. And then the third day, I would have urethral irritation and bladder irritation. And I was like, what is, I mean, it was so predictable. And he was baffled. It's like, dude, I'm telling you every time. I mean, I was their support group leader for our local hospital. This is the way it presented for me. Vaginal, vulvar, urethral bladder, that first year or two. So what the hell was that? Now we look at this MAP research network that patients flaring often have candida in their urine. So could that have been a candida infection for me? I think it could have been. I think it could have been. And here's the problem. If there's any group of patients massively overexposed to antibiotics, it's us. It's us. You know, because what do doctors do? For our entire, doesn't matter how old you are. Doesn't matter how old you are. The odds are the first time you had these symptoms, somebody threw antibiotics your way. And the odds are for some of you, you've been on antibiotics for years. And some of you, no doubt about it, self-medicate with antibiotics. But you know, whenever you take all those antibiotics, what are you doing? You're killing the good bacteria that keep the fungus in check. And that's why I got the drug-resistant candida infection after taking Augmentin for 3 months, right? And of course, the other flaw here is that typical urine testing doesn't test for candida. So how would you even know if you have candida? You'd have no clue. Until now we've got this next generation urine testing. And this next generation urine testing, it will at least identify potential bacteria or potential fungi. I just had one done. I should print it out. Hold on a sec. Let me find it. Oh, where did it go? Hold on. Yeah, I'd love to show it to you. I have no shame. I'll talk about anything. I mean, I just think we're all in it together. All right, hold on. Okay, here, I'm printing it out now. Here. All right. So let's let that do its thing, and I'll come back to you. So there is no doubt, zero doubt, based upon this MAP Research Network data, that some of us have candida infections occasionally, and that may explain why we have flares. Oh, it's printing the second side. Okay, so isn't that interesting? But then, not to be left out, we started learning about viral infections in the bladder. And in fact, it was 7 years ago that researchers in Europe discovered a couple of viruses associated with Hunner's lesions. Now, up to that point, when you think viral infection, you think pneumonia, sinus infection. You're not thinking urinary tract. You can get a viral infection in your urinary tract. That is so. I mean, it's just not something that we even think about, right? But I think that our minds are being opened now about potential pathogens. And one of the things that I think is really important for all of us to be aware of is the critical risk of HPV, the human papillomavirus. Of the many strains of HPV, several strains are well known to cause cancer. So, for those people who have had throat cancer, rectal cancer, cervical cancer, and for a young patient that I was working with who was 32, 34, 34 years old, young mother, she had an HPV driven urethral cancer that was very aggressive, and they had to remove her urethra, her bladder, and she had total hysterectomy. And so we need to know more about um, uh, the connection between viruses and Hunner's lesions. It's so funny. I have several contacts over in Europe. And if you look at the European guidelines for IC, they're very clear. They screen for viruses before they make a diagnosis. And it's like, okay, when you find a virus, what do you do? And they went, we don't really know. So that's a new area that is under discovery. So if you've got Hunner's lesions, be aware that Hunner's lesions could be the Epstein-Barr virus or the polyoma BK virus. We also know from our own research that some patients flare when they have breakouts of herpes, and a human papilloma is the new one. And for those of you who are younger, the human papilloma vaccine is really, really, really important because these cancers are terrible, absolutely terrible. Okay, so here. So here is my next gen results. So I have had, just to kind of give you an idea of what it looks like. Okay. So for me last fall, I started having a lot of vulvar irritation. And I thought it was yeast because I had a hot heating pad in my bed. And I thought, oh my God, you created the perfect environment for yeast to grow. And it felt like yeast. And the first doctor thought he found yeast, but 5 months later, it's still irritated, right? And so we did a biopsy and they think it's chemical irritation. But I'm like, oh man, I want a next gen test. I want to see what the heck they can find. And so here are my results. Okay, so the company that does it is Microgen. And what it found, I don't know if I can show this to you. I don't know if that's clear. What it found is that I had Lactobacillus gasseri, 92%, Prevotella, 2%, a Streptococcus, which is common in the gut, 2%, and Gardnerella, which is very common in bacterial vaginosis. I thought, man, that is so odd. How the hell would I be exposed to Gardnerella? Because I'm not in a relationship right now. And then what they have is the antibiotic resistance recommendation, right? So they will show you, which antibiotic will kill that species. Interestingly, for me, it again found that I have a resistance gene to a specific type of antibiotics called aminoglycosides, also known as amikacin. You can see that it's actually in red. I still have no freaking idea how I could have gotten that drug resistance because I've never taken those medications. I'm assuming that it came from an animal that I ate that it had been exposed to that. But to me, while this data is somewhat debatable, and I'm going to be having a meeting with my gynecologist who pretty much thinks that that's normal, and I'm like, well, something's causing the pain down there. To me, what's really important is fungi detected, none. And I, as a patient, needed to see that. so that I can walk away from all the yeast stuff I was doing. Because if this test found no fungi, there's no fungi. Done, over. And so, again, kind of, I'm all about getting data. I want facts. I don't like people guessing. If I'm in pain, I want good, hard data. I want somebody to look at it. And in her case, she said, I want to biopsy it. I'm like, I'm all for it. Vulvar biopsy, not a problem. Do it. And to me, this is meaningful data. Okay. This is meaningful data. Okay. So now we've got the viral stuff. So we know some patients can have Lyme disease in their bladder. We know some patients can have Candida in their bladder. We know some patients can have virus in their bladder. Again, small population, not everybody. You cannot put all of your eggs in the infection theory basket. You cannot, because with this overall subtyping, it is absolutely undeniable that a massive number of patient symptoms begin after muscle injury, and they have nothing to do with infection at all. But some of you could potentially have infection. So this all got kind of stirred up in December when Dr. James Malone Lee from the United Kingdom got on Twitter. And he's been working with a very aggressive, appropriately so, group in Australia who is bringing up again the bacterial theory. And hold on a sec. Let me find this. He has published, done over 180 studies into bacteria. And I can give you his data here. Where is it? It's not there. I need page. Oh, here it is. Okay, cool. So now we have the modern day Dr. Fugazzotto, Dr. Malone Lee. And he and his colleagues are aggressively stepping forward and bringing up the bacterial debate again, appropriately so. And one of the key points that they are making that we all now clearly understand is that a typical urine culture does not identify enough bacteria. A typical urine culture might only identify 5% of the potential bacteria found in the urinary tract. Because, guys, it turns out that the urinary tract isn't sterile at all. There's lots of bacteria that are supposed to be there. There are beneficial bacteria in your urine, in your entire urinary tract. If you ever have a kidney stone, the kidney stones are covered with bacteria. Okay, so can a typical urine test identify all of those bacteria? Absolutely not. And at the AUA meeting this year, at the ESIC meeting this year, everyone pretty much embraced next generation testing as being much more specific and thorough and able to diagnose more. So here's what Dr. Malone Lee has been saying. So he's been an outspoken proponent on the role of bacteria in patients with urinary symptoms who have negative cultures. With more than 180 published scientific papers, much of his research is focused on chronic bladder inflammation, where he made a number of significant findings. Number one, that the microbiology applied to the routine midstream urine tests miss many genuine infections. Okay, we know that. That's true. I mean, this is all true. Number two, that the dipstick test for leukocytes and nitrites are substantially worse than culture methods, and that these tests should not now be used to exclude urine infection. So in other words, if you've got a positive dipstick, get to the doctor. If you got positive leukocyte, positive nitrite, get to the doctor. But he says if you're negative, we might still need to rule some stuff out. Okay. Number 3, microscopy of fresh unspun urine to count urinary leukocytes is the best test to determine if urine infection is present. And so that's what they do in their clinic now is you pee in a cup, they slap it on a slide, they look at it under a microscope, and if they see pus, they go, "Yeah, man, you got an infection." They might not know what type of infection is, but they believe that that identifies that an infection is of some type is happening. However, he says even that will miss 40% of the infections out there. Our next fact from his research, many persons with lower urinary tract symptoms are living with chronic infections that go untreated because of contemporary guidelines. Guidelines being that if you don't have a positive urine culture, that maybe you have IC. Okay. Number 5, many urine infections are caused by mixed colonies and mixed growths that are associated with important independent markers of urinary tract inflammation and infection. So, in other words, with 70 potential species of bacteria in your bladder, of which some are going to be pathogenic, is it always just one infection that's causing the one bacteria that's causing the problem? And the answer is sometimes it's a mixed infection. We call it a heterogeneous infection. It's not a homogeneous infection. It's a heterogeneous colony of bacteria. And when you ever look at if you look at some of the data with biofilms, when they break open the biofilm, it's not just one bacteria living in a biofilm, it's a whole bunch of different types of bacteria living in biofilms. What's even more interesting about biofilms is that it's not like a big sloppy colony. They're arranged in a specific way, kind of like in circles. And certain bacteria are in the middle of the colony, and certain bacteria are in or some are in the center, some are in the middle, and some are on the edges. And it's based upon the structure. Okay, so the concept of a heterogeneous infection is interesting. And last but not least, many urine infections involve intracellular bacterial colonization of the urothelium. So, in other words, infections inside the cells of the bladder wall by mixed pathogens that are, get ready for it, fastidious and extremely difficult to treat by conventional methods. So, who is the first doctor who used the word fastidious? Dr. Fuzzy. You can bet Dr. Fuzzy, who passed away some time ago, is smiling, going, finally, somebody is following my line of thought. Dr. Malone Lee's most recent study found that patients who had pus in their urine and who were treated with long-term antibiotics despite negative urine culture responded well to antibiotic therapy, and that if the antibiotics were stopped, most patients reported that their symptoms worsened and inflammation increased. All right, so who are you supposed to believe? Is it bacterial? Is it viral? Is it fungal? Or is it a muscle injury? Here's my position. The all or nothing theories fail. Anybody who says everyone has bacterial infection is wrong. Anybody who says everyone has Lyme disease is wrong. Anyone who says everyone has viral or fungal is wrong. They're wrong. We cannot make these big generalizations because, again, it is undeniable that a huge number of you watching this right now, your symptoms began after a muscle injury, and there's no bacteria. There was never infection in the first place. And when you get better with pelvic floor physical therapy, that kind of proves it, right? It's the all or nothing theories that fail completely. We are long past the days of believing that IC is a bladder disease in every patient. Today, we think of it more as a pelvic pain syndrome, and there are many potential triggers for the symptoms we associate with IC. From the urinary tract to the reproductive system, the pelvic floor to nerve dysfunction, patients and their doctors have to thoughtfully exclude other conditions to solve the mystery of their pelvic pain. If you struggle with very painful periods, it's important to rule out fibroid tumors or endometriosis. If you've suffered a significant pelvic injury, then an examination of your pelvic floor is essential. Do you have a super sensitive sense of smell or a wicked sense of smell? Or super sensitive skin and a wicked sense of smell? Then you might have some central sensitization going on. There might be some genetics involved for you, like there is for me. So the question is, could some IC patients have chronic infection? Yes. Yes. But you've got to do the work to try to figure out what it could be. If you're in pain and you're suffering, I don't want you to sit at home and suffer in silence. It's time to ask for some testing. So, the next generation DNA test is fairly mind blowing in this regard because now we finally have an affordable test that you can use to determine if you have a fungal infection or you have a weird bacterial infection going on. And again, you can have a Lyme disease test, which is a blood test. There are other things that you can do, but this is about due diligence here. We've got to solve your mystery. There is a mystery afoot as to why you have pelvic pain. And it's worth at least exploring it, in my opinion. Now, the way I concluded, this was the editorial in my magazine. Our magazine is at the printer right now. Our spring summer big double issue is at the printer. I'll be doing a reveal for that maybe on Sunday. Okay. So here's my conclusion. If you're curious, let's see, could some patients have chronic infection? Yes. And the next generation DNA urine test has revolutionized the identification of potential pathogens. If you're curious, this test will identify good bacteria, bad bacteria, and fungal pathogens. If you have Hunner's lesions, you could also ask for a viral next generation test. You have to call them and ask for that specifically. But you can't put all of your eggs in the infection basket. In hindsight, I now know that the most of the antibiotics that I've taken throughout my life for urinary symptoms would never have fixed my fundamental problem, which using the pain subtyping system is pelvic floor dysfunction and central sensitization. Okay, so what am I trying to say here? What am I trying to say? You are worth it. You are worth additional testing. If you're not getting better with therapy, if you're not improving, if you're getting worse, if you have other signs of infection like fever, chills, if you have a history of tick bites, if you've ever had anything like that, I think that you deserve the opportunity to have that test done. I do. I do. Now, here's something interesting that Dr. Malone Lee and colleagues are, and I would encourage you to follow me on Twitter, ICN Jill on Twitter, James Malone Lee. You can follow him on Twitter. There's an Australian group that is really pushing this. One of the points that they talk about, and I know that some of you watching this, a couple of you watching this might fall into this category. What about the patients who have negative urine cultures, but they do better on antibiotics? And when you take them off of the antibiotics, they get worse again, right? We see this a lot in postmenopausal women who are struggling with the genitourinary syndrome of menopause, where their skin is so dry, it's very, very vulnerable to infection, superficial injury, all that sort of stuff. And he argues that using the contemporary UTI guidelines, if you apply that to those patients and you take them off of the antibiotics, they get worse. And what does that mean? What does that mean? And should those patients be treated? with long-term antibiotics. Now, of course, the AUA guidelines say do not recommend long-term antibiotics. But if you're one of those patients where you have a positive urine culture that keeps coming back over and over and over again, then, menopause matters. Working on the cause of the menopause is important. You getting some estrogen in there to help strengthen those tissues so you're not vulnerable to infection is really, really important for many of us. But for those of you who have negative cultures, but you feel better on antibiotics, that's really what Dr. Malone Lee is focusing on. Is what does that mean? How can we diagnose them correctly and how can we treat them correctly? And it is a very, very big point of contention. You've got the anti-infection people out there and you've got the pro-infection people out there. And of course, you've got me saying, for God's sake, don't put all your eggs in one basket. We got to rule all that stuff out, fibroids, all that sort of stuff. But I think it's going to change some things for the better, for the better. Of course, the big problem with next-gen tests is how do you interpret the damn results? So I sent my results off to my gynecologist who was on vacation. So another doctor looked at it and went, Jill, we see all these in a typical vaginal swab. I don't think that any of this suggests that you have any sort of pathogenic infection. And my response back is, then why do I have redness and irritation and discomfort down there? There's got to be a reason why. Everything that we're doing is holding it at bay, but we're not fixing it. Could that be a fastidious infection is my question. Could I have a little Gardnerella from down there, which we would call bacterial vaginosis? And her answer was, I don't think so, and I'm not going to treat it. And that ultimately is the fundamental obstacle that we face is how do we interpret this? How do we interpret these results? And do we know what a normal biome is anyway? So my doctor was saying these are part of the normal biome. We don't see this as a pathogenic infection. And so for some of you, when you've got, like I was working with a patient earlier today who had 94% Antiproliferative in her urine, which is definitely that's definitely fairly abnormal. And they treated that, and then her Enterococcus went down. And because her Enterococcus went down, then I think her Klebsiella went up. So we still have a lot to learn to be able to identify what a normal biome is and how to interpret this data. But I hope I haven't confused you. I don't want to confuse you. I'm trying to give you history so that as you're in your groups and you hear people talking about the pros and cons of bacteria, you can understand that discussion a little bit more and know what to research and know what to look for. So does anybody have any questions on that specifically? Lo Simpson on YouTube says, how do you break a biofilm? Biofilms are amazing. They're, again, but I'm a nerd and I'm a geek. I like this stuff. So a biofilm is a thick, waxy coating that a colony of bacteria exude to protect them from whatever is in the environment. And biofilms are impervious to antibiotics for the most part. Biofilms are also impervious to heat sterilization. We also know that biofilms move along surfaces. So that's usually what drives nosocomial bladder infections in the hospital. Somebody has a catheter. They've tracked the biofilm moving up the catheter from outside the body up into the body. So biofilm, but in contrast, we now know that there's bacteria throughout the human body and that biofilms are a fairly normal way for bacteria to exist. And we even have bacterial biofilms in our brain to a certain extent. It's not quite as easy as it sounds breaking a biofilm. And do we want to break them all? so much to learn. It's like throwing antibiotics at everything. They knew back in the 1930s that was going to cause resistance, and we've done it anyway. So we have to understand the ramifications of some of these decisions. And we don't even know if it's in a biofilm. Does that mean that it's a safe colony of bacteria that's not pathogenic? I mean, I just don't know. We don't know. Carolyn says, I had pelvic floor therapy. My physical therapist told me everyone with IC has little ulcers on their bladder. Is that true? Absolutely not. No, that's not true. The only people who have real ulcers in their bladder are people with Hunner's lesions. And the data is anywhere from 5 to 10%, although somebody recently said it was 25% of IC patients. I don't have a source for that. I don't necessarily believe that. But it is only a small percentage of patients who have Hunner's lesions. And I have a picture of them. Oh, here it is. All right. So let's look. And if you were in Europe, when they make a diagnosis, every patient has to have iodo distension. And that diagnosis is based on what they visually see in the bladder combined with pathology results from the biopsy. Every patient in Europe has a biopsy also. Okay, so here is a Hunner's lesion. This is a really good picture of a Hunner's lesion. So there's a central area of deep inflammation, and then there are spokes that come out of it of inflammation. And so when we treat a lesion, they will inject a steroid right into the middle of the lesion to fight the inflammation, or they will cauterize it. Hyperbaric oxygen therapy has also been found very good for this. So if this is indeed a viral infection, the center of the infection is probably in the center of the lesion. But again, that's very cutting edge new research. There's no consensus on that, but there are published studies, including a study presented at AUA last year, which found the Epstein-Barr virus in the urine of patients with lesions. Okay. Now, she might be confusing that with petechial hemorrhages, glomerations. And here, these are good pictures of petechial hemorrhaging. So these happen when you stretch the bladder. You take a normal person and stretch their bladder, they're going to have spots on their bladder because, the bladder is like a balloon, right? So it starts small and then it fills up and fills up and fills up and fills up. And its normal capacity might be here, but if you have a distension, they put it to here. And when you do that, it breaks things. It breaks skin, it breaks tissue. And so that whole petechial hemorrhaging that we thought was 25 years ago, more than that, in 1987, when the National Institutes of Health created their first diagnostic criteria for IC for research studies, they said that a finding of petechial hemorrhaging was a definitive diagnosis for IC. But then about 5 years later, another research team did the same test on people without any bladder symptoms at all, and this happened anyway. So the finding of petechial hemorrhaging is no longer conclusive as a diagnosis of IC. Carolyn, why are you on the IC diet? Well, we have to look at the subtypes. We've got five subtypes: Hunner's lesions, bladder wall injury, pelvic floor injury, a nerve injury, pudendal neuralgia, and number 5, central sensitization. So if you've got Hunner's lesions, you've got wounds in your bladder, diet matters. You pour acid on those lesions every day, they're going to hurt like hell. You take a multivitamin. I was working with a patient who had a lot of lesions. She was taking a multivitamin every day, and that was hurting her bladder like heck. If you have chemo-induced cystitis, some sort of chemical injury, then you have an injury to your bladder wall. Diet matters there. If you've got pelvic floor, if your symptoms started with pelvic floor, so here you've got an entirely normal bladder. I got it upside down. So you have an entirely normal bladder, and then you've got pelvic floor muscles that get injured. And what do? They go bam. And your pelvic floor muscles get very tight around your bladder. And because your muscles are so tight, your bladder is not getting the blood flow it needs to be healthy. So think about it. You squeeze your arm, bam, look. it drives all the blood away. And look at how long it takes for the blood to go back and for my skin to be, to turn a normal color again. Well, that's what tight muscles do to the bladder. It deprives the bladder wall of blood flow and oxygen and nutrients. So you could have bladder sensitivity as secondary effect of the tight muscles. And of course, if you've got IC subtype 5 central sensitization, then you've got sensitive nerves anyway. You've got sensitive nerves anyway. And so your bladder might be more easier to irritate because your nerves have a lower sensory threshold. There was something else I was going to say there, but it just went right through my brain. So diet, so I call it the chicken versus the egg dilemma. Which comes first, the chicken or the egg? The reality is that they're both probably involved, but one is primary, one is secondary. And we want to make sure we treat the dominant one first. If you're somebody who you just keep taking bladder medication over and over and over again, and nothing is working for you, it is time to have a pelvic floor assessment. In fact, all of you should have had pelvic floor assessments at your first appointment anyway now. Because underneath it all, if you've got tight muscles restricting blood flow to the bladder, no bladder treatment is going to work well. What's going to work well is restoring blood flow by getting those muscles to relax. Does that kind of make sense a little bit? So any good IC clinician now, at your very, very first appointment, they check your pelvic floor. And if your pelvic floor is tight, you get referred to physical therapy. And we have the research to back it up. We have a very large national clinical trial, multi-center clinical trial released in 2008, which found that pelvic floor physical therapy dramatically improved the symptoms we know as IC: frequency, urgency, pressure, pain. And when that study came out, we all were forced to go, oh, maybe it's not just the bladder in some people. Maybe there's muscle issues involved. And now consensus is, among the people that I work with, is that the pelvic floor injury is the largest subtype of patients. Does that make sense, Carolyn? I hope that helps a little bit. All right. I've got something stuck on it too. Do it. What was I eating? Oh, I was eating an apple. It's an apple skin. Got it. Okay. Hello, Karen. Hi, Susan. Hi, John. Hi, Betty. Hello, Melissa. Toby, thoughts on kratom for pain? Actually, we have an article on that in our summer issue of the IC Optimist. Oh, I have it right here. This is my draft that we were editing 2 days ago. Let me get that for you. What I can tell you is that the FDA is now tracking fatalities associated with kratom, and that kratom is frequently contaminated. I think with heavy metals. Hold on, let me find it. This is a really big issue. Let me tell you, we worked our tish off on it. Hold on a sec. What page is it? Oh, you know what? I think we took it out. Okay, hold on. I've got that little article right here on this other computer. Let me get it for you. Easy peasy, my friends. Easy peasy. Okay, it's 2019 spring. Here it is. Got it. Okay, so it was a consumer alert. With the opiate guidelines forcing millions of pain patients off of their medications, it's only logical that patients would look for alternatives. Kratom has a small but vocal following in the IC community, with some patients raving about its effects, but there is a hard reality to its use. More than 90 deaths in the United States have been caused by kratom between July 2016 and December 2017. Guys, it's 6 months. According to the Center for Disease Control, often the result of people combining kratom with other substances such as fentanyl, heroin, benzodiazepines, prescription opioids, and cocaine. Kratom is a plant native to Southeast Asia, has been growing in popularity as an herbal supplement. Low doses may have a stimulant effect. Higher doses may produce an opioid-like effect. The FDA has issued a number of alerts over the years due to contamination from high levels of heavy metal to the discovery of salmonella. Warning letters have been sent to companies who have made claims that kratom can be used to treat opioid withdrawal and pain. The DEA considers it a drug of concern and has recommended that it be classified as a Schedule 1 substance. So I'm not on the kratom bandwagon. Man, 90 fatalities in 6 months. We need to know a lot more about that. That's deeply concerning, in my opinion. Mary says, I think mine started because your mom always made you wash everywhere with lots of ivory soap, also bubble baths. It's if you're sensitive, that certainly would have been aggressive. I grew up, we never used bubble baths because my mom was sensitive to bubble baths. My sister was sensitive. I don't think, I think I've taken maybe two bubble baths in my life. One as a kid, one as adult with an ex-boyfriend who made me I was watching TV, he came in and said, "Oh, I made you a bubble bath." And I was like, "Oh," he goes, come look. And I didn't want to burst his bubble. And he'd made a bubble bath with Irish Spring liquid soap. And I looked at it and I looked at him and I looked at it and I looked at him and he was so proud of himself. I was like, "Oh, thank you, honey." And I shut the door and I made the foolish mistake. I knew I couldn't be in it for more than 5 minutes, right? But it's like I felt obligated to get in there to prove to him that I was appreciating what he did for me. Holy hell, that was agony. I had to fly home the next day, and I kid you not, I think I cried the entire plane flight from the bubble bath irritation. The flight attendant thought I was crazy. They all thought I was leaving my boyfriend. It was like I wouldn't cry over that. What I was crying over was this bubble bath. Tony says, "Thank you for the mindful woman." Oh, I'm so glad you got it, and I hope you like it. Oh, awesome, Tony! You should at some point in time write something about why you like the book, and so that we can share it with others. I mean, what are you reading in the book that you're finding really really helpful? Melody is going to start bladder rest tomorrow. Good luck with that. Don't do a full dose. We're all sensitive. At least just take one capsule. See how you do first. Deb says she has urea plasma in her bladder, and that's what your urologist thinks triggered your IC. It wasn't picked up for over a year. Amanda, did you receive my email for information to ship the winning product? No, I did not, hun. And I have it right here. I did not get your email with your address. So if you could send that again, ISEE Network at mac.com, because I have a post-it right here for your thing from our last meeting, and I know I did not mail it out. Hello, Julie Beyer. Julie Beyer, you guys, we have somebody famous in the room if she's still here. Julie Beyer is the first registered dietitian to ever be interested in IC because she is an IC patient herself. She is the author of 3 books on the IC diet: Confident Choices, Customizing the IC Diet; Confident Choices, a cookbook for IC and OAB, and then I remember the title. She has a book for registered dietitians, Confident Choices, a guide for dietitians, something like that. Julie and I have been friends for many, many years. She is one of the absolute heroes of the IC movement. She's also a contributor to the IC Diet Project over at icdietproject.com. Julie does coaching as a dietitian. You can work with her directly, and you can reach out to her for information on that, or you can sign up for it through our website. I would just ask that you respect her time. because we have all been working with ISEE for 20 years or longer. And back in the early days, it was all for free, but now we all have retirement funds that we're trying to build. And so don't expect to be able to spend a long time with any of us without maybe, a donation or something. Simple, quick question. I have no problem answering that. But we just have to respect the fact that we have a lot of wisdom to share over 20 to 25 years, and we just can't keep giving it away at some point in time. So when you sign up for coaching with somebody as professional as Julie, there's going to be a fee attached to it, and she deserves every penny of it, and you will not regret it. You will not regret it. Susan says her vulvodynia vestibulinia is off the charts right now. It just will not calm down. You get an increase when your bladder symptoms, when this is going on. The stinging, burning on fire sensation is unreal when it does not let up. Ice pack and pain pill. Finished Medrol dose pack, no change. Maybe yeast. Started something for that today as I'm not waiting to go back to the doctor where I was just at twice to get a test. Oh my gosh, you were describing me at times and my doctor is baffled. So, Susan, I would encourage, at the AUA meeting 2 years ago, not last year, but the year before, there was a fabulous class on pelvic pain that was taught. And it included IC and IBS and vulvodynia. And with the vulvodynia, the first recommendation is number one, you got to get any and all chemicals touching you away. That's what they think triggered. That's what my gynecologist thinks triggered my current bout with vulvodynia is I had gotten into the habit of wearing mini pads. And it's so, God, I can't tell you the number of women I've said, don't wear mini pads. If you're sensitive, don't wear mini pads. And yet for me, clueless. And I don't know about you, but like I really like Always mini pads. I used to really like Always mini pads. And every now and then you get a box and open it, and just the smell of glue would be terrible. And I just got into the habit of if I smelled it, I just took them back. I mean, I'm not going to put glue down on my vulva. I'm sorry, I'm not going to do it. And I'm normally really good about that. And this time I was in a hurry. I opened up a new box, slapped it on my underwear. I was out, didn't even smell it. And that was when my vulvar burning started again. And the irritation is literally the shape of a mini pad. This was 5 freaking months ago. And my doctor thinks that it's just a bad reaction to the chemicals in that mini pad. Okay, so getting back to this class, they say number one, you got to get rid of all the chemicals. Anything touching you down there's got to go. No mini pads, no douches. Be very careful with your soaps. The only soap that's recommended is Basis for sensitive skin, which I have right here. If you've never seen Basis before, you can get this at Walgreens, CVS, but it's often buried. It's hard to find because it's a smaller brand. But we have it in the ISEE Network store, and this is like $3.49. Okay, you can't use any fabric softeners. You've got to be really here. Hold on. Oh my God, that's so embarrassing. I sit on a towel and everything was all weird down there. Okay. Your laundry detergent, you cannot use anything with scents. You got to use a free and clear, either all free and clear or Planet. I go from detergent to detergent to detergent. It's like every 6 months, and then I feel like it's irritating me, and I move to something else. I have that new laundry egg coming, which is supposed to be the best for sensitive skin, where they just use minerals in it. So that should be here any day if it's not here already. I'm going to try that. No fabric softeners. And in the class, they said, if you got vulvodynia, they want you to be taking a bath twice a day, 20 minutes, and they recommended Aveeno. And hold on, I've got it. Let me show it to you. there. Oh, here it is. All right, here it is. A Vino soothing bath treatment. My mom has wicked vulvodynia. Oh, we've all, my sister, myself, and my mom, we all. I had terrible vulvodynia in high school, and then it went away when I was in my 20s. But anyway, let me just open this up here so you can see it. So like it's just a little pack of an oatmeal like stuff that you just put in your bath. So in the class, they said twice daily, warm sitz baths with vulvodynia. And they talked about, here, where is it? Where is it? I got too much stuff in here. Keeping track of everything in this office requires tremendous discipline, and I'm not always good at it. They actually recommended a Fairwinds Cannabis, a vaginal insert and a rectal insert by a company called Fairwinds Cannabis. And again, that's from the American Urology Association class on pelvic pain. It's a beast when those nerves get irritated, Susan. Girl, I'm with you right now, really, and it's annoying. Also, I use coconut oil. I just use coconut oil down there several times a day, and that really at least keeps things fairly calm and contained. Can Hunter's lesions completely heal? Yes, Lena, they can. They absolutely can, and they do in patients randomly, and we don't necessarily understand why. But they do. They also healed with the Lyris therapy. Amy says, if my bladder is flared, it's all irritated. And you can have different types of flares, son. You can have a flare from eating the wrong food. You can have a flare from ovulating. You can have a flare from sitting in a car for a long period of time, which is a pelvic floor flare. You can have a flare from sex. There are different kinds of flares. You can have a bladder wall flare or a pelvic floor flare or a stress flare. Amanda says she's dreading the 4th parade and fireworks, so walk with no bathrooms and pain you'll be in with your IC and UTI. Well, normally parades go downtown, and normally there's a Starbucks nearby. And if you're walking in the parade, you can leave the parade and go to the bathroom. Nobody stop you there. If you're sitting there watching the parade with your family, you got to do some advanced planning, hun. You got to do some advanced planning. If you need to, you can always, where it depends, and hope you won't have to use it. Or better yet, a travel john. Man, whip behind a bush and use a travel john. Look, where is it? Here you go. Okay, I mean, seriously, people, you all need a box of these in your car. When you have this with you, it takes away 90% of the stress. I've had these in my car for 20 years. I have never used one. But just knowing it's there, if I need to use it, takes so much of the stress away. It's like, oh my God. So what does it look like? So literally, this is a 3-pack. This is what pilots use, especially if they're in a long haul flight. I remember after 9/11, I had an American Airlines pilot walk into the ISEE Network office, and we were talking about it. And he goes, Jill, a lot of pilots have IC and prostatitis now because we're not allowed to use the restroom. So they had to keep the cockpit door. So, man, this one you whip out a travel gun. All right, so here's what it looks like. Look. seriously, just hold it between your legs and pee into it. You can find a way. It's filled with a crystal. You can see that. So what happens is that the liquid immediately solidifies, so it will never leak. So you just pee into it, wrap it up, throw it in a trash can, and you're good. I think there's so much stress about restroom access that sometimes the stress of it makes our symptoms that much worse. But just knowing you got one of these in your car is really cool because it'll take the stress away. Then you park on the side of the road, you open the front door, you open the back door, you're facing a hill. Nobody has a clue you're peeing there if you need to. But again, I've also decided I will always have one of these on a plane because I can always put a blanket over my lap if they won't let me use the restroom. Of course, I will get very aggressive before they would do that. But if necessary, I'll use that. Put a thing over my lap. Marnie says, can't get rid of the Candida. Drives you crazy. So, Marnie, Candida is becoming more and more drug resistant. I mean, my Candida glabrata drug resistant infection was 15 years ago. And I'm not lying. It took 2 freaking years to kill it. I was the Candida poster child at my local Kaiser Permanente. I saw every gynecologist on staff. I had a gynecologist scream at me, "You could not have yeast. You've taken diflucan." And I just went, "Prove it. Do a swab." Lay back down, put my legs up, "Do a swab, hun. Check it out." She came back and she apologized and went, "Oh my God, you have yeast." And it's like, yeah, I wouldn't be here if I weren't in pain and I didn't have yeast. My Candida flared with sugar. It flared with milk sugars. Anytime I had anything with milk sugars, bam, that Candida went crazy. And if you've ever made bread and you're preparing the yeast, what do? You put it in warm water with sugar and it starts to bubble and grow. That's what yeast does. Candida is yeast. So when you do milk sugar, you're feeding the yeast and it's going to grow. And so Candida, so Marnie, look at your diet, look at any extreme sweets. Ice cream for 2 years, one bite of ice cream would make that Candida glabrata flare. So I had to stop the ice cream. I stopped the pastas because those are high in sugars also. There's also a really good book. It's right on the shelf back there, The Yeast Connection in Women. And there's another book, The Yeast Connection, had some pretty good dietary suggestions. And again, you could potentially do the next gen test and see what they identify, the type of species of Candida that you have. There are many different types of Candida. Candida glabrata is just one. It might be interesting to identify that Candida. And I don't know if they can give antifungal recommendations or not through next gen. I don't know. But if you want to talk about it, feel free to give me a phone call. We can compare strategies because, man, we are all in it together when it comes to yeast infections. Susan says, I had the ureaplasma urine test 1.5 years ago. It was negative. They considered that specialized. Guess they have not heard of this. The next generation testing is really at the upper echelon of urology. It's in the upper echelon of infectious disease specialists. The regional doctors have no clue. They don't know about it. They haven't been trained about it. They don't know how to interpret these results. And even at the national level, sometimes they don't know how to interpret the results. But it is the future for sure. 100% the future. Wendy says, "You look amazing, Jill." Thank you. Thank you. I appreciate that. I had to work at it. I don't know. I really have to work at this sometimes. I scared myself when I looked in the mirror this morning. It's like, Tabby, what causes repeat infections? Generally, okay, so the first piece of this puzzle, Tabby, is you've got to start tracking the exact type of infection. You no longer can except a doctor saying you have an infection. Your immediate answer is what kind of infection? Because you've got to start tracking. Is it E. coli? Is it staph? Is it strep? Is it enterococcus, micrococcus? If it's the same infection over and over and over again, you either have a drug resistant infection or you have a source in your environment that keeps inoculating you to that infection. And according to the Center for Disease Control, the most common source of that infection is a bathtub or hot tub with jets. So you know how some bathtubs will give you bubbles. Normally, the tubes are installed at a slight angle downwards so that when water gets in them, the water will drain out. If the tubes are not installed correctly, if they're level, the water will collect in them. And if they're installed at an upward angle, you get a pool of warm water that becomes a bacteria factory. And then, of course, when you fill up your tub with water, the water's going into the tube, it's forcing the bacteria out, and bam, there's your source of infection. The second, if it's a different bacteria every time, then they start looking at your immune system. But this is kind of where the whole urinary biome is kind of tricky because, again, I was working with this one patient today. She had really bad enterococcus. They treated that. And then the next time she had really bad Klebsiella, even though she hadn't been exposed to anything new. And so we're trying now to understand how these bacterial populations relate to each other and how when you change one, that might cause another one to grow. You know, it's going to be exciting the next 5 years. But in the meantime, we're all, waiting and hoping and praying they'll come up with good answers. The third thing, Tabby, that you've got to look at is estrogen atrophy. The single most common factor we see in recurring repeat infections is a diminishment of the mucosal barrier in the vagina, in the urethra, and the bladder due to the lack of estrogen. And I want you to think about it this way with respect to bladder function. The bladder is the only organ in the human body designed to hold toxic waste because urine is body waste. Urine contains ammonia and urea and all the byproducts, all the crap we're all exposed to. Cigarette smoke, man, if you're a smoker, you got like 20,000 potential carcinogens living in your urine, okay? I mean, that appear in your urine at some point in time before you pee them out. So how can the bladder hold irritants, ammonia, for hours at a time and not get damaged? And the answer is that your bladder is like your mouth. It is a hollow organ covered with a really thick coating of mucus. And that mucus, Dr. Parsons calls it the mighty mucus. That mucus is estrogen dependent. So when you're young and you have lots of estrogen, you have lots and lots of mucus. And that mucus acts as a barrier between bacteria and the cells that the bacteria could infect. But when you start losing estrogen, you start losing mucus. Thus, it's much easier for the bacteria to reach the cell to infect the cell. And so, in women with recurring bladder infections, and they've studied them in depth, I attended a great lecture by Dr. Anthony Schaefer who talked about this in depth. He basically said, we never diagnose a woman with recurring infections as a simple infection. It is always a complex infection. Then, in their research, they were culturing these women every day. They were taking vaginal swabs, they were taking urine samples. They've really tried to understand these recurring infections. And what they consistently found is that the bacteria was in the vagina 24 hours before it arrived in the bladder. And that then left them to wonder, why has the vagina become a safe haven for infection? And the answer goes right back to estrogen atrophy. That when the vagina loses that nice, thick, robust coating of mucus, it too can become easily infected. So that is why generally a menopausal woman with recurring infections, or if you've had a hysterectomy, even at a young age, and you're getting recurring infections, is usually also accompanied with an estrogen cream that you would use vaginally to improve the environment of the vagina so it is not so favorable to bacterial infection. Okay? If you're curious about the next gen test, um, go over to this website, bladderhealth.org, and there are a whole bunch of videos from urologists using it who explain it. So next generation DNA urine testing, go to bladderhealth.org. I built this website last summer, a year ago, because the research is undeniable. Gosh, my hair is going everywhere, all over my face. So Rebecca says it took a lot of research. So she really dove into this research all. And the problem with both the broth test and the DNA test is that they aren't reliable. I don't think reliable is the right word. I think the right word is interpretable. And Dr. James Malone says the best marker for chronic UTI is using a microscope, looking at the sample to see if there is pus. Of course, the challenge with that is then now you've got pus, but how do you identify how to treat it correctly? Jessica says that she flares due to certain foods and drinks, and you follow the IC diet and you've been better. Awesome. Because I mean, the other undeniable fact is our diets are filled with crap that our body was never designed to defend itself again, like soda. You know, I mean, think about it. Your body was designed for life 5,000 years ago. The only time you ever had acid in that environment was when you ate unripe fruit when it was seasonal. And so we can argue successfully, at least for me of Swedish and Norwegian descent, that my body never had an opportunity to develop defenses for the acid level today because we didn't have those acids 5,000 years ago. The only fruit we had was berries, maybe apples. Compare that instead with somebody who of Latin American descent or somebody who grew up around the equator where you had maybe pineapples, mangoes, papayas, where you might have had more fruit consistently, or even Mediterranean where you might have had oranges and lemons. Your body over time may have been able to build some evolutionary defenses for acids, where mine, being of Norwegian descent, up by the Arctic Circle, we did not have any exposure to that, if that makes sense. That's my personal take on that. Sarah said, after birth control, it struck severely, and even after stopping it, it remained. Hormones are challenging, hun. I mean, I gotta say that, in my 27 years, is it 20? How many years? 26 years as a support group leader, there's always been, I mean, it's like once a year. I mean, it's not common, but I will say that maybe once or twice a year, I talk with a patient whose symptoms were triggered by some sort of hormone dysfunction. And the patient knew implicitly that the hormones were the problem and went through the whole rigmarole with the typical icy stuff. Nothing worked. And when they got the hormones stabilized, that's when their symptoms improved. But for some people, they were opposite. Some people had high estrogen, some people had low estrogen. So there wasn't a trend that I could report to. Amy says you were diagnosed with IC last year. It's been difficult journey. You were diagnosed based on your symptoms and minimal relief you got from multiple bladder installations. I do not know what type of IC I have. What test should I ask for? Hon, I want you to go over to our website and I want you to watch the video on the subtypes of IC, okay? And with respect to tests, there really aren't tests other than a pelvic floor examination. And if you have severe symptoms, blood in your urine, then having somebody look in your bladder to see if you've got untreated lesions or Hunner's lesions is important. But other than that, we're ruling out other stuff: fibroids, endometriosis, pelvic floor injury, chemical injury to the bladder if you've been through chemo, stuff like that. It's this is a potpourri of potential causes, a potpourri of potential causes. And the odds are, Amy, to be quite honest, and I say this to every patient that I work with, please don't walk into a doctor's office and say you've been diagnosed with IC, because you fall down the rabbit hole of whatever their beliefs are. I want you to be really specific and say, doctor, I am here because I have this weird pain on the left side that feels like it's my bladder, and I'm trying to figure out what is triggering this pain. You need to get that doctor focused on your anatomy. Don't even mention the name. It's like, okay, I am getting up 8 times a night. I do not know why. Can you please help me figure out why? Or, doctor, when I try to pee, I can't. I have to sit there for 30 seconds a minute before I can release my urine. Can you please help me figure out why? Or, doctor, when I have sex, I get pain when I ejaculate. I'm trying to figure out why. We really need to get them and you focused on your anatomy before you start talking about treatments. Because it would be a real sad for you to spend 2 years with bladder stuff only to discover after the fact you've got a muscle problem, or vice versa, right? So it's a comprehensive workup now. And you as a patient have to direct it, because your doctor may be treating IC out of a textbook, and he might just be saying, oh, let's just throw some Elmeron at it. And it's like, no. Before we talk about treatments, let's go over these symptoms. And I want you to look at my pelvic floor. Let's see if that's playing a role in it. Let's do a urinalysis. Let's see if, they got to do your history, hon. And you are a mystery, an anatomical mystery to be solved. Oh, and speaking of titanium dioxide, guess what else has titanium dioxide in it? Elmeron and Cystacue. We learned that in the last couple of days. All righty. I have more that I could say there, but I best not say anything right now. How do you know if it's central sensitization? Sarah, the signs of central sensitization are acute sensitivity throughout your body. So you have very, very sensitive skin. People with central sensitization, we're afraid to try medications. We're afraid to try supplements, honestly, because we have no clue how we're going to react. And I'm one of them. Like, I cut everything in tiny portions because I'm so freaking sensitive to stuff. It's ridiculous. We tend to be sensitive to foods, not just for our bladder, for our guts. I mean, we have a sensitive bladder, we have a sensitive bowel, we have a sensitive stomach, we have a sensitive rectum, we have a sensitive mouth, you name it, we're sensitive everywhere. But kind of the hallmark symptom of central sensitization is a really wicked sense of smell. If you can smell stuff that other people cannot smell, and if smells almost produce pain for you, that really is a sign of systemic sensitization. And usually that's the gift of our ancestors. Think about it. They needed to be sensitive 5,000 years ago to find food, to smell good food and to smell bad food. So I don't personally interpret central sensitization as a disease process at all. It's the gift of our ancestors, and we've got to respect it. And the odds are, if you are, you're already respecting it because you're not using scented candles and Febreze and all that crap in your home. But sometimes central sensitization happens after injury too. Rebecca says, I have hyperalgesia and allodynia of the pelvic floor muscles. Would this cause a lot of pain similar to chronic UTI pain? Yeah, I think it would, hun. I think it would. Allodynia, I think it could. I went through a period of allodynia so allodynia happens, guys, when the nerves near the injury also become involved and become very sensitive. And so I went through a point my first summer where you could just do the slightest touch on my lower abdomen and it would hurt. And that was because the nerves all down there got very, very hypersensitized. That did calm down. That's not true anymore. But patients can go through periods of allodynia or hyperallodynia. If you've got vulvodynia, for example, and you have allodynia, wearing underwear can be painful. Touching a pubic hair can produce pain. And so that tells us that those nerves are hypersensitized, and our goal has to be to calm those nerves down. And again, I'm living proof that that does happen because it went away from me. But I'm probably back into a little bit of a hyperalgesia, at least with my vulva, with what's going on right now. Because even spraying water on it hurts a little bit for me. Menopause sucks. What's the treatment protocol for central sensitization? Oh, as a matter of fact, I happen to have my handy dandy treatment summary. This was from Chris Payne's article that he wrote about his subtypes, since he was the one that proposed these subtypes. He says there are overlapping syndromes: fibro, IBS, IC, allergies, anxiety, depression, catastrophizing. The whole anxiety thing we look at as a chemical sensitivity to adrenaline. So he says, number one, look for untreated anxiety and depression. We've got to address that, because that's only going to exacerbate things. And it's all about chemical neurotransmitters and adrenaline processing there. Um, um, the goal of therapy is to restore daily activities, life, living. Pain is the primary focus of treatment. So in this case, um, let's say you've got rectal pain, vulvar pain, and bladder pain. Okay. So if we treat the bladder pain and we treat the vulvar pain, but we don't do anything about the rectal pain, it's still like a jackhammer on the nerves. And so the approach here is to try to address every pain generator. Anything that's triggering pain should be treated. And speaking of triggering pain, woo, I gotta stand up. Hold on a sec. I can only sit. How long has it been? How long has it been since we've been doing this? I think we're at 90 minutes. Man, I gotta get up and move around. I'm old. You want to see this new chair? Let me show you this new chair I got. It's cool. All I know is when I sit in my big desk chair, I can only sit for about 20 minutes before all my muscles start spasming. It's crazy, but I can sit on that. Alrighty then. Cindy Rogers asked, what's central sensitization? Just means that the nerves in your body they have a lower sensory threshold. That might not be the exact correct name, but basically what it means is nerves have a threshold before they get triggered, right? So as an example, if you did this, it doesn't hurt, right? You can, it doesn't hurt when you just kind of manipulate it. But when you squeeze to a certain point, you hit that threshold and the nerve turns on and generates pain. So with central sensitization, what they have found is that, how do I want to explain this? Let's see. I give you the academic explanation, or at least the ISEE research explanation. The bladder has two sets of nerves. It has the alpha afferent nerves, which control frequency, urgency, and it's got the C fiber, which controls pain. The alpha afferent nerve is a nerve that's very easy to turn on. It's meant to be easy to turn on because it's a nerve that tells you when you need to pee. The C fiber, the pain nerve, is very hard to turn on. It takes some sort of trauma to turn it on. like holding urine for a very, very, very long time. At some point in time, that C fiber gets triggered. Now, a lot of you just have frequency urgency, and that's great because it's just the alpha afferent nerve getting irritated. But when that C fiber gets turned on and you have bladder pain, we have two therapeutic targets. Like it's, we got the one nerve, and then we got to address the pain on the other nerve. And what research studies have found in patients with central sensitization is that the nerve threshold of the C fiber gets lower. It gets easier to turn on. And so the question is why? And the answer is, for some of us, it's genetics, and for others, it can be the result of injury. Another good example of that is think about somebody who, there's always somebody in the family who, when a storm is coming in, they go, "Oh, my knee hurts, my knee hurts." And at some point in time, they suffered an injury to that knee. They broke that knee, right? So when you suffer a major injury, like you break your knee, you break a bone, you traumatize the muscle, and you traumatize the nerve. I mean, those nerves are there too. Well, the bone heals and the muscles heal, but what about the nerves? Do the nerves really heal after a major injury? And the answer, of course, is yes. But what happens is that sometimes the threshold, the sensory threshold of that nerve, and again, I'm not sure that's exactly the right word, the threshold of that nerve to get stimulated drops a little bit. And that's why they might feel knee pain when a storm is coming in. So that same process can kind of happen in the pelvis too. But more likely, there's just genetics at play. I was born sensitive. And for those, y'all know, listen, there are people watching this right now who know exactly what I'm talking about. You were told as a kid you're sensitive. People said, get over it, you're just sensitive. You can't turn off how your body's built. And it's really sad that the word sensitive has been weaponized with kids. Because now that we understand it physiologically, it makes a lot more sense. Thank you, Susie. And happy 4th of July to you too in San Diego. I bet that's a big celebration down there with the Navy base. So you guys are talking a little bit about detergents. Our rule of thumb had always been that the mass market detergents, including all, was not necessarily ideal. Um, uh, but they all keep changing, and formulas keep changing, and it's a bit of a it's hard to find a detergent that works. The 7th generation gets good reviews. Nellie's, I think, if they're approved by the Environmental Working Group, I used Planet for a while. I really like Planet. I still do a lot of stuff with Planet, the Planet detergent, which is a powdered detergent. But I'm really excited to try my laundry egg that's coming, and I will give you guys feedback on that. They say it's really good for people who are sensitive. All right. How many of you right now are rubbing your belly? That was me. You see, I was just, that's what God, that's what you do. Just, it's like you're just like walking around with your hands on your lower belly sometimes. And it doesn't even hurt. It's just tight. It's tight because I've been sitting too long. Molly, newly diagnosed with vulvodynia. It's horrible. Don't know what to do next. Waiting to see your urologist. So Molly, listen, you don't need to be freaked out about the vulvodynia. Vulvodynia means the nerves on your vulva are irritated. Now you got to figure out why. And the odds are it's probably some sort of chemical that is irritating you, like a mini pad, like a douche, like spermicide. And it's all about calming and soothing those nerves. And let me tell you the one thing that you've got to get. When I went to my first vulvodynia support group meeting when I was like 23 years old, the older ladies there took me under their wing, and this is what they taught me. Now I'm going to teach you about it. This, my dear, is your friend. Oh, here, let me get one unwrapped. This, seriously, everybody out there, $2.99. If you're a member of the ISEE Network, we give it to you for free as part of your membership package, is a perineal wash bottle. You fill it up with water, especially when you have vulvodynia. The odds are, if you've got screaming vulvodynia, peeing is agony because urine crossing your vulva hurts like hell. We call it urine burn. So what you do is you can either fill this up with cool water and spray yourself as you're peeing to dilute the immediate effects of the urine, or after you're done peeing, rinse yourself off and then pat dry. The reason why this is so important is toilet paper will not wash the chemicals off of your skin. Water will. So we want to get all that urea, all that ammonia off of your vulva. And so again, this great vulvodynia worker meeting that I went to, they sat me down and they said, this is the secret right here. And they were right. I mean, honestly, no treatment worked for me like this did. Once I started doing this, everything started calming down. And of course, I really like taking sitz baths. And of course, you can now take a sitz bath with Aveeno, which is just an oatmeal. Oatmeal is very soothing. I use an oatmeal cream on my arms now. I really, really like it. Really takes any pain off of my arms. Tanya says, what about using Replens for moisture for vulvodynia? Hey man, whatever works for you. You know, there's also aloe. Desert Harvest Aloe makes a gel. So Desert Harvest Aloe personal gel, that might be interesting. You can see what it looks like. It's just a gel. It's fine. It's fine. And then I'll show you the other one. Hold on. Another one you can try is V Magic. Medicine Mama's V Magic. It's they call it an intimate skin balm, and it's made with organic olive oil, avocado oil, and I think this one is the closest in consistency to normal mucus. And then this is all about the coconut oil. You want to this is emerald, additive free, doctor formulated, cold press, non-hydrogenated, 16 ounces of coconut oil. And I have to say, this also is really, really awesome. But it's about finding what works for you. Some people like to use tea bags, cold tea bags. That's an old Asian approach to it. So let me put these back. One sec. Alrighty then. What brings vulva on? What makes it happen? And it's usually chemical irritation. It's usually some sort of chemical trauma to those tissues down there. But it could also be an abrasion, a physical abrasion of some type. It could be a reaction to latex if you're using a latex condom. It could be a reaction to a spermicide. It could be a reaction to cottonelle Wipes, you got to be really careful with if you use any wipes down there. Those chemicals are really known for being very irritating to those tissues. Um, Mini pads, always mini pads. Any of the mini pads, they use a layer of chemicals to absorb the fluid, and then when it gets wet, all those chemicals gas off right onto your vulva. Hello, Cheryl. Here, I got to check YouTube here. Hold on a sec. I'm sorry, YouTube. Becky says, my doctor said always pads in particular are not to be used. He mentioned the brand by name. She uses organic cotton pads by NatureCare. Casey's asking, is there any new news on Lyris? And the answer is no. Lyris has been deprioritized by the company. We have nothing new. I have sent letters. They've sent me a letter back. And they just say that they moved on. And it is a tremendous tragedy. Big pharma, my friends, big pharma. It's all about making the money. If they don't think it's going to make them enough money, they're going to move on. It's either that or they weren't happy with the clinical trial results. They didn't publish the last, at least I don't think they published the last round of clinical trial results with Lyris. So I don't know what happened with those. I know that it was very hard to fill the study because the entry criteria, the entry requirements for that study were really strict. Tammy says, thank you for discussing vulvodynia. I have vulvodynia, ISEE, and endo. When one flares, it all hurts down there. And it's hard to tell. You know what? That isn't that interesting. I mean, I've been thinking about that a lot because I'm going through this vulvodynia flare myself. And it's like your whole pelvis gets turned on in a way. So I was at the store yesterday and I was rubbing my stomach and I was going, okay, it's not your bladder, and it definitely wasn't my bladder, but rubbing my bladder felt good. But what I could feel was my pelvic floor being weird. Those adhesions were pulling, and they're pulling right now. Yeah, I mean they're definitely pulling right now. So Kathy says, thank you for talking about infections today. I have chronic resistant E. coli infections, and I appreciate all that you do. Kathy, man, girl, I really wish you luck. Guys, the thing with E. coli is E. coli is a master at defeating antibiotics. It's a fascinating bacteria. There's a researcher named Scott Hultgren, Hultgren. He has a big clinic studying drug-resistant E. coli infections. And I attended a lecture that he gave at a conference years ago, and he was showing E. coli under an electron microscope changing shape. And so when it senses a threat, it goes from being round, at least this was back then. Now this could all change because I haven't attended a lecture by him in 10 years, right? But what I remember him showing in this picture was that this round E. coli became a long, skinny noodle. And it changed its shape so much that a white blood cell could not recognize it as an enemy to be killed. That was one of the theories back then. So I hope that, I hope that they can find the magic button for you, the magic bullet for you that would kill that E. coli. But in the same sense, staying hydrated, and maybe doing D-mannose, all that self-help stuff that you can do that your doctor would tell you to do. I would definitely keep doing that. And also, girl, making sure that if you're in estrogen atrophy, you got to have them look at the quality and health of your skin because that could be contributing. Also, again, you specifically have to look for a source of E. coli in your daily life. Is there any chance at all that there's something in your daily life that keeps it re-inoculating that with you? Like a hot tub or a bathtub. Tanya says, when I had PMS, my gynecologist said I would feel better when I hit menopause. I think he lied. Well, it's nice not having periods and cramps like that, but the whole loss of estrogen skin thing is terrible. Bladder Builder is working for Kathy Reichen. Awesome sauce. I love that. Beverly says, I have had ISEE for 36 years. It's so exciting to see how far we've come with research and insight. I just got on Facebook and I'm impressed with you. Thank you. Thank you, Beverly. You guys kind of need to know it's my job. I read about IC every day. Like I was going through all the European IC studies last week. So understand that when I give my meetings, your local urologist isn't going to know 90% of what we talk about because they don't read the journals for IC. They're working their ass off just trying to care for patients. And so, again, the purpose of these meetings is to give you valuable information that you can read about. And if it's intriguing, bring it to your doctor and have a discussion about it. And you got a 50-50 shot. Some doctors love it when you bring information and they say, thank you. And then other doctors say, please don't tell me what to do. I'm the doctor here. And that's always more tricky. Tanya, how do you keep the coconut oil solid? I was just talking to somebody about that today. Put it in the fridge. Just cool it off. Because the thing with the coconut oil is even if it's solid, as soon as you put it on your fingers, it's going to melt. So you should be able to put it in your fridge. Thank you, Angie. All right. So Molly just asked the $6 million question. She goes, what medicines do you recommend? I just started amitriptyline. Well, number one, I shouldn't make any recommendations because I am not your doctor. I can't make medical recommendations. My job is to educate you so that you can learn more about this and then talk with your doctor about it. When you're thinking about treatments, you can't talk about treatment until you understand your physical reality. What is going on with your unique anatomy that is triggering these symptoms? And so ultimately, the right way to have a discussion about treatments is to first talk about what your unique anatomy is. So some of you may have Hunner's lesions. Hunner's lesion patients tend to have more severe symptoms. You tend to have blood in your urine. You tend to have a lot of pain that just doesn't really go away. You tend to, if you've got these big bleeding lesions in your bladder, then the odds are food is very tricky, and the odds are you probably stopped eating a lot of food. Some patients with Hunner's lesions are down to eating like 5 foods. And when I ask them how many foods are you eating, they go about 5. It's like, all right, I think, has anybody looked in your bladder? And it's like, no. It's like, it's time, don't you think? It's time for somebody to look in your bladder and try to figure out why you're so sensitive to foods. So if your symptoms are so extreme like that, Molly, eventually we don't want to guess anymore. We need the facts. You need to, that if I'm in pain and it's long-term and chronic, I want somebody to look at it. And I don't wait, man. It's like I usually get in there and look at it, which is why I've had 1, 2, 3 doctors now look at my vulva in the last 5 months, try to figure out why it's being so freaky. So if your symptoms are extreme, having somebody look in your bladder is really, really important, because if you do have lesions, if they treat them correctly, your things will improve quickly. But one of the great tragedies in the IC patient population are patients who have hydrogestensions. The doctor sees Hunner's lesions, the doctor diagnoses Hunner's lesions, but does not treat them. And that the reality is that Hunner's lesions will not respond to other stuff nearly as well as it will respond to a lesion-specific therapy, like injecting it with a steroid or cauterizing it. Okay? The next subtype is bladder wall driven. So these are the patients with bladder wall injuries of some type. It could be a chemical injury from chemotherapy, or from you drinking way too much soda or diet soda or coffee or whatever, at some point, the bladder, like any other part of the body, can be hurt. And generally, it's hurt with some sort of chemical exposure. And also in this subtype are patients with estrogen atrophy. The quality and health of your skin is an important question. It's something important to know, because when we know the health of your skin, we will then know if you got dry skin on your vulva, then you probably got a dry bladder, and that might be why your bladder is more sensitive. And so your therapy for that might be a hormone cream. You could potentially have a chronic infection. The question is, what kind of infection? Bacterial, fungal, or virus? I would encourage you to rewatch this video when it gets posted, because we spent the first half an hour talking about that. At your first appointment, they should have checked your pelvic floor muscles. And if your muscles are tight, they would send you to physical therapy. If your symptoms are positional, where you're fine when you stand, but when you sit down, you get searing pain, sciatica-like pain, pain shooting down your legs, up your spine, then you might have a nerve entrapment from a very, very tight muscle. And then ISEE subtype 5 is central sensitization, which means that we've got nerves that are sensitive just throughout our body, not just our bladder. So amitriptyline is tricky. What it does is when they give you a low dose antidepressant, it calms nerves down. It's not a pain medicine. It's not like you take more when you're in pain. In fact, some patients overdose because they don't understand that distinction. That generally, when you're doing amitriptyline, you do a little bit every day over time, and slowly over time, that kind of calms nerves down. The challenge with amitriptyline are the side effects. It has a lot of side effects. Dry mouth, dry eyes. It can give you, for me, it gave me a very irregular heartbeat. It gave me PVCs. My heart was beating very violently. So if you're somebody who you can't take Benadryl or epinephrine because it makes your heart race, and if amitriptyline makes your heart race, that just may not be the medication for you. It can cause weight gain easy, because there's something about amitriptyline that makes you crave sugar or crave carbs, and so before you know it, you've gained 20 pounds. We call it the Eleville 20. And most recently, and I just did an article on this in our magazine, we have yet another research study of several in the last 5 years that have linked anticholinergic medications like amitriptyline with cognitive decline and dementia, especially if you're older than 55 years old, but even if you're younger. And so the newest study that just came out in the Journal of American Medical Association said that patients who take antidepressants like amitriptyline or bladder muscarinics like Detrol or Diazepan, that if you take it every day for 3 years, that there is potentially a 50% risk of dementia. This is very, very, very new, but not new, because we've had studies leading up to this for 5 years, right? So with the amitriptyline, you gotta, if I were you, I would talk with your doctor about options other than amitriptyline. I just sent an email to the chairman of the AUA IC committee that created the guidelines, where I said, shouldn't amitriptyline be moved from step 2 to step 4, given these new risks? In contrast, the antihistamine Vistaril hydroxyzine, which is also a step 2 treatment option, which is also has an anticholinergic effect, but in the latest study did not lead to a risk of dementia or cognitive decline. They do different things. Amitriptyline calms nerves down. The antihistamine reduces histaminic activity from mast cells, and they kind of go hand in hand. And so I could not take amitriptyline. I lasted 3 months, and then I had a year's worth of heart issues because of it. So if I were in your shoes, I would have another discussion with your doctor and say, you're learning a little bit more about these medications and some of the side effects, and ask if there's something else with less risk or less side effects. Maybe. I wasn't going to talk about that today. This is very new, and I was waiting for information from some of the doctors that I work with on how to approach it. Um, okay. Um, Molly, let me do this. Let me go over the 6-step treatment protocol. Hold on a sec. Here it is. Okay. So, 25 years ago, IC patients were treated so differently. I mean, some doctors did surgery, some doctors said there was nothing, some doctors, did Elmeron. I mean, it was all over the place. It was just there was no consistency at all in the way IC patients were treated, not only in the United States, but around the world. So the American Urology Association convened a committee of 30 IC experts and patient advocates to create a consensus-driven guideline statement on how to diagnose and treat IC. And they did a freaking good job. And so from a treatment standpoint, they arranged the treatments in 6 steps. And the steps are arranged with respect to the risk of adverse event. So they don't want you to do the big stuff that's potentially really dangerous and life-changing without first doing the easy stuff with few side effects. So we've got 6 steps of therapy based that the American Urology Association has recommended. So, and these steps are really ideal for, I think, IC subtype 2 bladder while driven. I think that they rock for that. So here, hold on. Let me get these in order. So these were the guidelines produced by the American Urology Association, released in 2011, revised in 2014. And you can go, I want every single person here, there's no excuse. You go to auanet.org. In the upper right-hand corner is a link for guidelines. Click on that, go to the guideline page, search for the IC guidelines, and then print them out. 40 pages, 40, 50 pages long. You need 3 copies of it, one for you so that you can highlight it. Nobody will ever be able to mess with you if you walk in with guidelines. You walk into your appointments with the AUA guidelines, nobody can mess with you because that's from the National Association. Nobody can dismiss them and say, oh, you got that off of the internet. No, these are the formal guidelines from the American Urology Association. One copy for you, one copy for your doctor, because the odds are your local urologist has never read them. And always save one copy and leave it in your car. If you ever have to go to the emergency room or urgent care, you're going to walk in with one copy for whoever's treating you at urgent care. Okay. So auanet.org. So here are the steps that they confirmed in 2014. And like I just said, I think that we should talk about revising them a little bit. So in step 1, they want you to get your water intake up. Come on. If you're dehydrated, your urine's super concentrated and irritating. So we have to make sure your urine is nice and dilute. If your urine is a pale, clear yellow, you're perfect. If your urine is dark yellow or brown, you're dehydrated, and that urine is more concentrated and irritating to your bladder wall. If your urine is clear, you're drinking too much, and you're going to mess your electrolytes up. Okay. Number 2, diet modification. Any good IC doctor is probably going to give you a list of the foods to avoid, like the coffee, the green tea, the soda, the artificial sugars, the tomato, the orange, the lemonade, stuff like that, because you're having bladder symptoms. We know those are going to contribute to them. And I will tell you right now, the patients who suffer the worst are the patients who drink 1 cup of coffee a day. If you've got bladder wall injury, 1 cup of coffee a day, your bladder is going to struggle to heal with that daily acid erosion. In step 1, they also want they suggest the supplements like Preleaf, who sponsors this, by the way. So in fact, I had a lovely meeting with them yesterday. I get to talk with them a couple times a year. Preleaf. Preleaf is calcium glycerophosphate. it doesn't act on your bladder. It reduces the acid level of your urine. So if you're going to go eat something that might be risky, you can take a pre-leaf beforehand, and that might reduce the acid load and make it less risky. Okay, so we want to thank GSC Healthcare Solutions and Pre-Leaf for sponsoring this live broadcast. I'm waiting for a sign. We'll have a sign in the back for them, or a sign on the screen when we start streaming. Also in the supplement category, just to give you some ideas, now the AUA guidelines does not mention brand names. They just don't. They can't show favoritism that way. The supplements that are being used by IC patients at this point in time are Bladder Rest, which is a new supplement replacing Cystoprotect, Bladder Builder, Desert Harvest Aloe, or Cysto Renew. Again, if one of you are calling, I'm not going to answer the phone. Sorry. Leave a message and I will call you back when I can. All right. Also, muscle relaxation is step one. Okay. There's no harm from relaxing your muscles. And if you happen to be somebody with tight pelvic floor muscle, seriously, people, you're going to have to do something about those tight muscles, right? Learning how to relax your muscles is important. And in the newsletter I sent out to our members last week, Beaumont Health, the top IC Research Center, has released all of their guided relaxation audio tapes for free. You can download them from their website. So go back to the last ISEE Network e-newsletter and you can find the link for those. And acupuncture. We had a new research study presented at AUA showing that the patients in this study who did acupuncture, all of them were able to get off of their pain meds. So acupuncture is real and viable. Step 2, physical therapy for pelvic floor dysfunction, oral medications like hydroxyzine, Elmeron, Elavil, although now all of those are bladder installations like rescue installations, and of course pain care. Molly, the only oral FDA-approved medication for IC Elmeron has now been linked to macular disease, pigmentary maculopathy. And so our pickings for treatments are getting a little bit on the slim side. But that's okay because we have some, at least we've got supplements that we can try. Step 3, you know, and I mean, we have a lot of talks about why is the bladder so irritated for some of us. And there are so many potential contributing factors. I mean, from age to chemical exposure, all that sort of stuff, those all matter. Ultimately, though, I think our diets are so screwed up and our exposure to chemicals is so high, and we're eating so many poor foods instead of real healthy fresh food. I really think a big part of getting control is to get control of your diet and walking away from the fast manufactured foods and getting back to eating real food, real meat, real vegetables, fewer grains, you know, and getting back to that. Okay. Step 3, hydrodistension with cystoscopy to treat Hunner's lesions. So this also, the test itself might actually help improve some symptoms temporarily. It is to be done low pressure, short duration, rather than the old way of doing it, which was high pressure, long duration. If you have Hunner's lesions, these are treated with fulguration, laser therapy, or a steroid injection. Lyris, although that is now no longer available, which is sad because it was the first treatment in history to heal lesions in 2 weeks. That's a whole nother story. And I need to add hyperbaric oxygen therapy to this. Step 4 is neuromodulation, ankle stimulation or InterStim, or Botox. Ankle stimulation is much less invasive, much more inexpensive than InterStim. No surgery is involved. So if your doctor's talking neuromodulation, you always want to look at the less invasive one first. The reason why is because there are hundreds and hundreds and hundreds of very severe adverse events with surgical neuromodulation with InterStim. And we've gone through the MOD database in these lectures before. You can do that online. Go to the FDA database, go to the FDA website, fda.gov, search for medical device database. It's known as the MOD, MAUDE database. And you can search for it yourself and you'll see all those adverse events. Step number 5 is cyclosporin. Cyclosporin is a much bigger medication that bigger is not the right word. It's an aggressive medication that is known for a lot of side effects like high blood pressure, but it is remarkably helpful for people who are immune compromised. And so it's definitely a group of patients, including a very good friend of mine who's used cyclosporin and is doing remarkably well with it. But you got to really monitor side effects like blood pressure with that. And the last step, of course, is surgery. Thankfully, this is rarely used for IC. All right. So there's your steps. The things the AUA no longer recommends is long-term antibiotics, which, of course, with today's today's discussion is, challenging. We no longer do Bacillus calmette-guerin or racinoferatoxin. We no longer do silver nitrate, chlorpactin, high-pressure hydrodistensions, or long-term steroids. All right, so that's straight from the American Urology Association, Molly. And so based upon their guidelines, what they would say is before you do the Elavil, have you tried the supplements? Because the supplements have much less side effects than the oral medication, amitriptyline. So you might want to consider that, hon. Talk to your doctor about it. See what your doctor has to say. And again, go to auanet.org and go read the guidelines for yourself so that you can walk in so strong, so knowledgeable, so informed that they can't laugh at you and tell you don't know anything. I promise you, you walk in with the AUA guidelines, you bring your medical care to a whole nother level. Urologist said he could make more money treating cancer patients and kidney stones than IC patients. That's true. Molly, you live in Canada. It's so hard to get into a doctor. Molly, honestly, the vast majority of Canadian IC patients that we work with come down to the US to get treated, and they usually go see Ken Peters outside of Detroit. If you're in Ontario, he's an hour away across the lake. And if there's any way that you can get yourself down here and afford that visit, you might find that, Canada healthcare is about 10 years behind the world. It just is. It's getting slowly better, but it's pretty rough up in Canada. Canada's kind of like the UK. Your medical system is really dominated by, at the very top, just a couple of doctors who determine everything. And for many, many years, those doctors didn't believe in IC. So there were no classes taught, very few classes ever taught about IC in medical schools. And so I was just working with a patient up in Canada who wanted to start a support group. And I was encouraging her to start a new Canadian IC organization. And you might want to think about that, of which the goal is not only patient support, but the goal is medical care provider training. That there should be classes on IC up in the Canadian system, and there just aren't that many. So you guys really have a rough time, and I'm so, so sorry. But that said, girl, information is power. Again, you walk in, and by the way, Canada does have new IC guidelines. The Canadian Urology Association released IC guidelines 2 years ago. So go onto Google, search for Canada Urology IC guidelines, and print those out. And I bet you money that the doctors don't even know that they exist. And that would be a very good document for you to have. And it's not as big as the American guidelines. Tanya says Benadryl was on the list for dementia, and it's helped you with some nerve issues, but you're laying off of it. Tanya, I think that's a very smart thing to do. I think that's very, very smart to do. Let's go down to YouTube here. Lisa, awesome. I'm so, girl, good job. I'm so glad you got out of the house. Well done. I agree. I got out of the house too a little bit. All right, guys. I think it's time for a giveaway. What do you think? Think it's time for a giveaway? I think it's time for a giveaway. Question is, what are we going to give away? Isn't that the question? What should we give away? I only have so many samples. You know, that's the challenge. What do I have? Well, let's see. Let me look at the date on this. Nope, that's expired. Can't be pre-leaf. That's expired. Nope, can't be that. What's the date on this? Oh, that expires in 2 years. Anybody want some low acid coffee? I don't have a lot of that either. I'm sorry. I need to go up to the warehouse and get some more. Not that I mean, I got to be really careful. If I could, I'd just give it all away to everybody because we're all IC patients, but you know, obviously I can't do that. So here's your giveaway. I'll give you, here's a bladder rest. Bladder rest, the newest supplement that is being used by IC patients. So let's do it this way. I'm going to, it's always challenging coming up with the right way to do this. I have to set up my screen so I can see what you're writing. Okay. I'm writing down a color. A color. The first person to guess the color is going to get a free bottle of bladder rest. You can vote. You can do it multiple times. Feel free. And those are good guesses so far. Okay, come on, Facebook. You guys are slow. YouTube is beating you big time. Not yet. Not yet. Nope. Lori Lehigh Demand. Oh, got it first. Lisa, you were second. Orange is the color. Orange is the color. So sorry, Lisa. Lori got it first. So Lori, I need you to send me an email with your contact information. Since you're on Facebook, if you're my friend on Facebook, you can send it to me that way, or you can just email me ISEE Network@mac.com. So Lori Lehigh Demand is going to get a bladder rest. And of course, my pen just ran out of ink. So this is yours, girl. If I don't hear from you in 24 hours, it's going back up on the shelf. Okay? And I'll save it for someone else. So if you want it, you got to email me. ICNetwork@mac.com. Lori Lehigh Demand, you are the winner. All right, my friends. Last call for questions. Last call for questions. Because I got to go fix dinner. Fix some dinner for the folks. You're very welcome. Okay, do I know when we'll have Peora? Yeah, 2 weeks. They just finished the label. They just got the labels in today. So Peora we should have in 2 weeks. Peora is palmitoethanolamide with racinoferritoxin. Toxin. It's a very close match to the formula used in the ICPEA research study. So when that's out, we'll be doing more on that. All right, guys, listen. If there's the single most important thing I need you to remember from this chat, and I'm looking at you right now. I'm looking at you. I'm looking at the green dot. I'm looking at the green dot. This is not your fault. You have done nothing wrong. I don't want you carrying any shame. I don't want you carrying any blame. I don't want you thinking like you're damaged goods. I don't want you thinking like you're unlovable or unworthy of the love of your family and friends. You are no different than someone who is hit by a car. You deserve love, care, support, and compassion from everyone around you. One of the challenges, though, is because you can't see this, people often don't believe it, right? And then we also start to doubt ourselves. And there's somebody in here who knows what I'm talking about. You have done nothing wrong. You are not the problem. What you are is hurt or injured. And we are on a journey together. You are on a journey with your medical care providers to try to solve the mystery of your pelvic pain. Every day, I need you to do 3 things. Number 1, do something to give yourself some comfort, spiritual comfort, whatever rocks your, whatever floats your boat. If you like to go to church, great. If you like to go to Joel Osteen, great. If you like to get out and walk in nature, great. I need you for 15 minutes to find a place of peace. Just a place of peace. Then, and 30 minutes would be even better. I need you for 15 or 30 minutes to do something that will support your health, especially your bladder and your pelvic pain. Whether it's driving by Starbucks instead of stopping, whether it is going and fixing a really good IC friendly meal, whether it is calling your doctor and making an appointment because you've waited too long and you're suffering. Every day, do something. I don't want you to do big things. This is not about making a big giant step that's overwhelming. I want you to do little things every day that will build a good, solid foundation of your success. And then, last but not least, man, we got to get your knowledge level up here. I want you to be, I'm nobody special here. I'm an IC patient just like you. I just had somebody tell me that my life was over. My life was over and that I would always live in pain and that I would always be, what was the quote? What did he say? God, I can't believe I forgot it. I say this all the time. You know what? Oh, I had a doctor say you will always be a burden on your family. I was 33 years old. I'd been burned chemically. I'm a burden on my family. I went, oh, hell no. No, I will prove you wrong, you son of a bitch. How dare you say that to me? I needed that because up to that point, I was hiding in my bedroom, crying my eyes out all day and night. Except that at nighttime, I'd go into my living room because I didn't want my family to hear me. And I wouldn't flush the toilet because I didn't want them to know how often I was peeing. And I really had given up. And then I had this jerk of a doctor at the time say, you will forever be a burden. And that woke me up. And I went, wait a second. I have 3 college degrees. I have an award from the White House. I have my brain. I have my hands. I have my intelligence. I will prove you wrong, you son of a bitch. How dare you say that to me? I started my first support group from my bed. A year later, started the ISEE Network. I'm no different than you. I just got pissed and decided to work on it. I decided to fight. Fight. I want you to fight. I don't want you to be aggressive. I don't want you to be mean. I don't want you to be rude. But seriously, don't walk into any doctor's office looking down. Look them in the eye. They're not better than you. They're people too. It's about treating each other with respect and having a discussion. Don't put a doctor up on a pedestal. You have the right to ask questions. And if they don't want to answer your questions, then maybe it's time to find another doctor. This is a team effort here, right? It's a real big team effort. And ultimately, in the end, you are the captain of your ship. You pay them. They don't pay you. You pay them. You're going there for their expert skills. And it is you discussing your medical care with your doctor that will determine your path. Don't give your power away. And for God's sake, please don't be one of those people who call my office and say, I've done everything and nothing worked. And when I say, well, tell me what you've tried, and they go, oh, I don't know. Like, seriously, did you have a bladder installation? Yeah. Well, what they put in your bladder? I don't know. Oh my God, do not be one of those people. Keep some records. You know, I have, if you're an ICN member, you can download off of your member page uh, our medical diary, you know, our medical information kit, where you can track everything. And you got to be able to track stuff, because there's nothing more frustrating for me than working with a patient who's so passive that they expect the doctor to do everything. And the reality, people, is that the doctor can't do everything, because there are some things that you undoubtedly might need to change. Like if you were a junk food junkie, if you were addicted to coffee and soda and your bladder is finally screaming, it's not, the doctor's not going to fix that. You got to fix that. You got to fix that. This wonderful body is a gift from God, you know, and or whatever your faith might be. It takes work, and we are awfully abusive to it at times, right? So we're going to do this together, my friends. We're doing this together. All right. I'm going to go fix a nice healthy meal. I think of I either have mushroom pasta, though the pasta, you know, I don't like the carbs from the pasta, which means I'm not going to eat a lot of it, because if I eat wheat-based pasta, I blow up like a stuck pig. I do quinoa pasta for me personally. Or we're going to do fajitas with chicken and bell pepper and stuff like that, which is completely ICEE friendly. So, all right, my friends, I will see you later. As always, feel free to email me, icenetwork@mac.com. Follow me on Twitter, ICN Jill on Twitter, because I'll be announcing our future broadcasts on Twitter. Also, for Facebook pages, please subscribe to our Facebook page, or like our Facebook page. On YouTube, please subscribe to our page. People on Facebook, would you please come on over YouTube and subscribe to our YouTube, because I don't know how long we're going to be I mean, I want to stay on Facebook as long as I can, but ultimately in the end, it doesn't allow me a lot of flexibility, and I want to get over to streaming software, which means we'll probably go to Twitch. But anyway, it's all a work in progress. All right, my friends. See you later. Happy 4th of July. Hope you have a great time tomorrow. Even if it's at home, go sit in the sun, watch the fireworks, smile as much as you can, make somebody's day. Even if you're feeling rotten, help somebody else. You'd be amazed how much you feel better when you help somebody else too. And you can do it. I believe in you. Okay, see you later. All right, YouTube, my friends. We'll see you later.